extend a warm welcome to everyone that is present here today. I hope everyone has a seat. We've got a full crowd here this morning, which obviously we're very, very proud of, and we appreciate each of you for giving time out of your busy schedule. And I also want to extend a very warm and special thank you to Tift Regional Medical Center, Bill Guest, as well as Bill Richardson for hosting us here today. And to the panel, I would like to take a moment and introduce to my far left Senator Jack Hill, who is present with us, the Appropriations Chairman, along with Senator, wrong name tag in front of him, but Greg Kirk, who is filling in maybe for Ben Watson, who is a doctor. So I hope Greg doesn't do any surgery today. But all of you know Senator Kirk, what a wonderful individual he is, and we're very honored to have him. Along with Senator Renee Unterman to my left as well, who is the Senate Health and Human Services Committee Chairwoman and does a remarkable job and a wonderful individual and ally and champion on various health issues for our state. To my immediate right is Senator Dean Dean Burke, and he is also a physician out of Bainbridge and does a wonderful, wonderful job for us. We appreciate him. Senator Chuck Huffstetler also is a member of the committee. We appreciate him from the Rome area and does a wonderful job. Also, a newly elected Kay Kirkpatrick, who is also a physician out of Cobb County and the Fulton area. We're very proud to have her with us. And then also Senator Doc Rhett, who is here with us as well from Cobb County, and we're honored to have him. And before we begin, I would like to ask Senator Rhett to open us with an invocation, if he would be so kind as to do so.
Yes, sir. Bow our heads, please. Oh Lord, thank you for this day, our daily bread, and that we are here with an opportunity to make a difference in a lot of people's lives, not just our own, but millions across the state. Give us your wisdom and your guidance. Be with us as we try and craft meaningful legislation. And we ask this through Christ our Lord. Amen.
Amen. Thank you, Senator. Let me just make some opening remarks, if I might. In January, I created the Georgia Healthcare Reform Task Force so that we could prepare statewide for the challenges of healthcare reform. Today, we have 7 exceptional senators working with me to make healthcare better for all Georgians. Although the climate in Washington, D.C. continues to change by the day, and many of you, I'm sure, have been watching on the news like we have, I believe even more strongly that it is incumbent upon us to lead the state of Georgia forward to a better, more sustainable, patient-centered healthcare system. Regardless of what happens in Washington, the work of this task force is to focus on what is best for Georgia. It is up to us to find solutions that allow hardworking Georgians to keep more of what they earn. It is up to us to work with issuers, providers, and stakeholders in every community of our state to innovate and lower cost of care, premiums, and deductibles so that all of our families have access to the care we need at a price which we can afford. And it is up to us to lower our state's uninsured rate, which currently stands as one of the nation's very highest. Unfortunately, we must improve the way, or ultimately we must improve the way we pay for and deliver health care to patients across our state, especially here in rural Georgia, so that no matter which city, county, or region of our state you call home, you will have access to quality care. I am hopeful that our task force can lay the groundwork that enables the state of Georgia to obtain waivers by working with Secretary Price and the Department of Health and Human Services. Waivers that will give us the flexibility we need to take ownership from the top-down federal system and craft policies to better meet the needs of Georgians. I grew up in Gainesville with a single mom, and we often struggled to get by. I know what it's like to live in a trailer park, and I know what it's like to go without insurance. And I also know what it's like to wait in line to receive care at a free clinic. I understand that for too many families across our state, health care is either unaffordable or out of reach, or consumes too much of the modest wage hardworking people earn. In fact, the rapid rate of growth in healthcare costs has played a significant role in why too many of our families' incomes have remained flat year over year. Statewide, our poverty rate among children hovers at approximately 25%. In 40 counties, more than 40% of our children are living in poverty. That equates to about $25,000 for a family of four. With all the prosperity and economic growth that Georgia continues to attract, how can we allow this to continue? If we believe in conservative values and that our families are the bedrock of our society, it seems clear to me we must make certain that ladders of opportunity extend to every community, to every person across our state. We should keep our Peach Care and CHIP program strong, but we cannot fall into the same financial trap that so many other states have by stretching our Medicaid program beyond the limits that our healthcare system can sustain. Medicaid should serve those patients who need it most. That's how it was designed. And that is the only way it will remain viable for the patients who rely on providers, doctors, and nurses to accept it as payment. For the millions of other people across our state, those who work in small businesses or don't receive insurance through their employers, we should focus on developing strong and effective markets where individuals and families have access to more choices at affordable prices. That incentivizes access to primary care, which is one of the most vital reforms that will allow us to control long-term costs by keeping people healthier. In the long term, we should do everything possible to put people in charge of directly buying and owning their health care. That means working to create a level playing field, breaking down the barriers that cause wide disparities in the cost of insurance, depending on who's purchasing it, and empowering individuals and families to choose and buy the plans that meet their needs. Fundamentally, as I think we'll hear today, so much of what drives our healthcare system happens in local communities. Although we have to make sure we are thinking about Georgians across our entire state, I believe that the only way to move forward effectively is by addressing our challenges at the community level, one patient at a time. Now I'd like to call on Mr. Bill Richardson, who is the CEO of Tifton Regional Medical Center, to give a welcome and introduce our host, who will also be our first presenter. Bill? Let's give Bill a round of applause.
Thank you, Lieutenant Governor Cagle, and on behalf of Tifton Regional Health System, I want to invite you today, welcome you today to this Healthcare Reform Task Force. Thank you for those opening remarks. You've pretty much said what I wanted to say.
Sorry about that, Bill.
But I'm going to maybe reiterate some of the points that I think that were important in what you said, Lieutenant Governor. Healthcare reform. What topic today in the psyche of American life is more volatile and evokes more emotions and opinions than healthcare reform? It's a top of mind issue for all of us, and certainly it is for us as well. Implicit in the term reform is that something needs to change because it's already defective. And in fact, that's what Webster says, it's defective. And what is this thing that's defective in our country? It's the U.S. healthcare system by whatever measure you want to take on it. Be it on the quality and patient safety front, be it on the variation in care that is delivered to patients, be it on the cost, the increase or the rate of increase in cost, or the efficiency with which we deliver care. All of those things need to be emphasized more as we seek to reform our healthcare system. And consider the magnitude of what it is we're doing. We are fundamentally looking to change the medical and delivery system we've worked under our entire careers, at least my entire career. It's been under the medical model that we're under today. And that's no small undertaking. This has at least been around since the 60s with the advent of Medicare and Medicaid. So the sheer magnitude of this is changing fundamental principles and precepts that we have on how we deliver health care. We want to change from a system that relies more on volume and rewards volume to one that promotes and rewards value. Value is maybe a vague term. I've hinted in my mind as to what value is in healthcare, and the Lieutenant Governor mentioned it as well. But certainly an improvement in patient outcomes and driving for consistency in the delivery of care. A decrease, and if not a decrease, at least a moderation of the rate of increase in the cost of health care. Enhanced access at the very primary care level so that everyone has access to primary care coverage within their communities. And then a coordinated effort among healthcare providers across a large population to assure that patients receive the right care at the right cost and at the right time. This is a huge undertaking, but in my mind, I don't use the word reform. Reform to me says we legislate something and it's going to change. I like the word transformation. And the reason I like transformation, and we use it in hospital circles, is because I think it's going to take several iterations of healthcare change before we hit on the right recipe, if you will, so that we can improve the health delivery system for all of the citizens in the state of Georgia. Our vision here at TIF began in 2010, actually before the passage of Obamacare. We chose to undertake this transformation for the very reasons I've mentioned above, and we adopted a vision, and that vision was developed and approved by our board of directors, our physician leadership council, and we rely heavily on to help guide our system, and our executive team who will have to execute on this system, some of whom you'll hear from today. And though this has been a daunting task, and we've met many challenges and will continue to meet challenges, that initial commitment to take on this reform initiative was made back in 2010, and we've been working diligently on it since then. And as I say, you're going to hear the story of TIF Regional's transformational journey from those among our staff, which is coordination and improving access to through patient-centered medical homes, of which we now have 15, and also through an accountable care organization that we call Care Alliance, wherein we're going to care for a defined Medicare population, about 6,500 individuals within our service area, and so it's primarily through the patient-centered medical homes and the ACO that we are seeking to reform the way that healthcare is practiced and delivered. I mentioned the commitment from the leadership is number one, but number 2 and 3 in no particular order is time and money, because we've had to underwrite this through our health system on our own, and there's no payment for this. It's something we've chosen to do, and our board has said let's allocate the funds that we have, if we can, to this effort so that we can move on down the curve and hopefully be ready when the market really changes and it's going to be mandatory that we do it this way. So our hope is to practice under this new model with those organizations and hone our skills and develop a skill set that will enable us to care for the entire population of patients, be that Medicare, Medicaid, self-insured, privately insured, self-insured businesses. We need that consistent model to apply to all the patients within our service area. And that's what our goals are here at TIF. The Lieutenant Governor mentioned some of the challenges, some of the top of mind challenges that come to mind. The lower part of Georgia, which we reside in today, is the largest part of the largest state east of the Mississippi. The sheer geography and the geographic expanse that we have to cover in in this sparsely populated area of our state calls for better coordination and better cooperation in delivering care. So geography down here is important, not to say that it's not in the other parts of the state, but certainly in this large part of the state, it presents challenges that we're just now coming to realize, which probably will underscore the need for telemedicine, which some of our Emory friends will be presenting later on. Another challenge has been the socioeconomic and health status of our population. I think in your slides, there's a slide that shows by county the health status and the socioeconomic characteristics of the population in South Georgia, and some of the typically trails the rest of the state, and those present challenges to us as well. And of course, it's the final challenge. It's difficult, probably impossible for most health systems to underwrite financially what it's going to take for reform. So these are the very real questions that I'm sure the task force will be examining as we seek the best ways to execute on a plan for all Georgians. The question is how, and that's what faces our panel and task force. My thinking is around the notions of partnerships that comes to mind. Not everyone can do this. The notion of partnerships and building scale, economic scale, and human capital. Because the professionals that are going to have to lead these efforts are data scientists and data analysts that we don't even know about. There are not too many of them around. So we need to come together and partner. When I speak of partnerships, I talk about hospitals, health systems, physicians, post-acute providers. We need to partner on how to best do this within our state. I also think partnerships between providers and the government is absolutely essential. The government can help us, of course, on the finance front, but you can also help us perhaps on some policy changes that would enable us to partner better to carry out these objectives. And partnership with insurance companies. Why can't we partner with Blue Cross? Or why can't we partner with Aetna and Tifton to run a trial basis on a care delivery system that will benefit certain patients to see if it works? So I think there's a good opportunity for partnerships with insurance companies and of course with private industry who also has a stake in this with the many thousands of Georgians that they employ. So partnerships just to fund the infrastructure to carry this out. The information technology required for healthcare transformation is enormous. And no one place can count on doing that themselves. It's going to take a cooperative effort. So in final, I'm going to say there's too much at stake for us just to ignore, which and I commend the Lieutenant Governor for this initiative that he's undertaken here with the task force. But we can't even leave it to those who can just afford to do it. Because if we do that, we're leaving a large swath of Georgia out of the picture. So partnerships come to mind. One thing that you did mention, Mr. Cagle, is I left a copy of an editorial from the Wall Street Journal, which is where I get a lot of my healthcare opinions. But they spoke of the 1332 waivers that is included in the Senate bill that is being debated in Congress now. And the 1332 waivers, which under the Obamacare legislation were highly restricted, almost prohibitive, you couldn't get them done. But under the Senate plan that may pass, it will include the 1332 waivers that will basically enable each state to customize their own health delivery plan, given the allocated dollars that we receive from the federal government. It'll allow our state to customize the health plan that's best for Georgians. And so this is something I'm glad to hear that will be a topic of the task force's study. So again, I want to welcome everyone and thank you for being here today. It's our honor and privilege at TIF to host you for this important meeting. And now I want to get some of those from the front lines who are executing on this plan to talk a little bit more about our patient-centered medical homes and our accountable care organization. I'm going to call on Ms. Jamie Branch, who is one of our data analysts extraordinaire. I'm not sure of her title, but I know she manipulates that data. and certainly Dr. Cameron Nixon. Dr. Nixon is our medical director and a true visionary among our physician leadership, and they're going to talk about our patient-centered medicine. So again, welcome.
Good morning. My name is Jamie Branch, and one of my roles here at TIP is to work closely with our primary care practices, coaching them through their patient-centered medical home transformations. And I'd like to just first start off with just a brief overview of what a patient-centered medical home is, and then have Dr. Nixon speak a little bit about why TIP decided to embark on this journey and some of the successes and challenges we've seen along the way. So, I think it's well known that over the past several decades, the United States healthcare system has continued to become more fragmented, less efficient, and more expensive. So according to the Centers for Medicare and Medicaid Services, the United States spent $3.2 trillion on healthcare in 2015. Despite ranking highest in overall healthcare spending, the United States ranked lowest when compared to 11 other industrialized countries on measures related to healthcare quality. So that gap between cost and quality sparked a report from the Institute of Medicine titled "Crossing the Quality Chasm," and it noted widespread quality concerns in the American healthcare system, and it called for a fundamental redesign. Healthcare needed to be patient-centered and quality-focused. So that fundamental redesign would become the patient-centered medical home model as we know it today. It's a philosophy of primary care that's patient-centered, involving the patient in their own healthcare goals. It's accessible, so it's providing access to care when the patient needs it. It's coordinated, minimizing that gap between the clinical care setting and the patient's home life. And of course, it's quality and safety focused, embedding continuous quality improvement into the practice's everyday functions. The overall intent of this model is to provide the right care at the right cost in the right setting. With that introduction, I'm going to turn the mic over to Dr. Nixon.
Thank you, Jamie. Say good morning to everybody. I guess in full disclosure, before I start, I should tell you that I was a naysayer to patient medical home when it started. So that's why they actually asked me to come and talk to you, because they made a believer out of me. So I just want to mention that. Why TIP Regional decided to move towards patient medical home. It was true trying to stay proactive, transform care to fill the triple bang. And that's really where we started this journey. Me personally, after practicing for 7 years in Tifton, the whole time, this wasn't working. What we were doing and what we were trying to help our patients just seemed like it just wasn't doing it for me anymore. So you're talking to a burnout physician who needed a change and really trying to help our patients. This is all about our community. About TIP Regional's journey, we started off with the overall 3 patient medical homes as a test model. If you look at our number of 4, 4 started because we moved to our largest clinic. That largest clinic composes about 12 primary care physicians. Those 12 primary care physicians encompass about 30 clinicians total when you look at our nurse practitioners and PAs. And then it's talking about 30,000 patients that are encompassed in our patient-centered medical home. And we continue to move this journey. We actually have 3 additional patient-centered medical homes we're working on at this moment. Hopefully we'll achieve NCQA level 3 certification by the end of this year. So why? What components are needed with this? You need a physician champion. Even if it's a naysayer like myself, you do need someone to start with saying, why do we need to change? What is the benefit of change, and how can we help our patients? We need a dedicated team, project manager, practice facilitator, data specialists, care coordinators, and outpatient care management. But because we're such a small rural setting, we need partners. We cannot accomplish this on our own. So what we did at TIP Regional is we actually partnered with GAFP, which is actually about $120,000 investment. And then you have to take those people off work so we can focus on redeveloping our care. And that takes additional lodging, wood. We actually traveled to the different areas in the state, Atlanta, Savannah, in order to try to focus on how do we transform care to affect our local community. How do we improve? And so this is where we started. Now, initial challenges. The first thing is the resistance to change. I mean, the only thing I knew before was how do we keep doing patient after patient after patient. Never knew how to really step back and look at our data and show what we're doing a good job. And I know for physicians in the room, if you tell me that, you know, if the data's great, the true study for us is they say they asked 96% of physicians were they top in their class. And everybody said yes, they were the top in their class. So that's how physicians think. And so the only way to change that is you have to get the data to the front lines quickly. We actually have to see what we're doing and which patients. And trust me, we know the patients who are doing well. And you show us those patients who are not doing well, we're going to get those patients feeling a lot better and doing a lot faster at that. Access is critical for us. And so that's what we're looking at. We've been thinking of things as this one big bunch of patients, and that is not how healthcare really works. Healthcare is more risk stratification. It is looking at individual populations of patients. How do we improve that population? And we have several examples showing you that. The other thing is our ongoing challenges is as we start delving into this data, looking at this, they're all different per insurance payer. There's so many different options. Nothing looks quite the same, which is to me just slows us down around delay in improving our patient care. A lot of our extra cost comes into trying to make the data match versus taking care of the people at the bedside, which I think is just a travesty. And so the other thing is coordination. We have some resources available. We just don't know how to get to it. Coordination plays a big part in what we do, and there's really not a lot of funding for that. And we're seeing that over and over again. A couple of things I wanted to show that really brought out for our health system what access really means. With the patient medical home, they talked about same-day visits. And when you talk about same-day visits, you're leaving open blocks in your schedule that you already are trying to see 40 people. And they're saying leave open blocks so people will come in and not go to the ER. And so, of course, I was a naysayer, to be honest with you at that point. But if you see our progress and what we found out is as we continue to bring patient medical home models up, access actually increased with same-day visits and ER visits drastically decreased. And this is happening actually quarter over quarter for our health system, which it shows that we're taking patients away from high-cost areas and putting them in a primary care setting to save not only better care for the patient, but it also reduces costs. And that is the true thing of this team approach of the patient medical home. And I think this is the key. The other thing with the patient medical home is it doesn't have to be just on my shoulders as a physician. It takes a team of us to make this work. We need all kinds of talents in this team in order to drive these improvements. And not everything has to be such high cost. We have opportunity to do this coordinated and save money in the process. And I think that's the true thing that we saw as we continue to look at the patient medical home. The other thing I brought out is getting down to the individual patient. And these are two patients of mine that I've actually had a chance to see and see their continuous improvement. This is patient R, patient G. They happen to be mother and daughter. But the year before we started the patient medical home, patient R had 16 ER visits that year before and 1 hospitalization. The year after we started the medical home, she had 5 ER visits and no hospitalization. Patient G, 13 ER visits, 7 hospitalization. The year after the medical home, 1 ER visit, no hospitalization. The key that we found out with this process, though, is that it was access for one, and we weren't able to address the real need. She was actually coming to the ER because she had dental abscesses. She was coming for antibiotics. And oh, by the way, while she's here, she ended up getting admitted for something else. And so if we addressed her by getting her to a dentist, we actually reduced all of this and saved the entire system a ton of cost. And so those are examples of what we can do individualized versus a system approach versus overall. And the other example is what we're doing now with our other patient medical homes, and I'll let Jamie tell you about that.
So I wanted to just highlight what we're seeing in one of our practices that is going through the transformation currently. And this is a pediatric practice. And they've chosen the HPV vaccine as one of their quality improvement measures to focus on. And as you can see, they've already seen great improvement, and some of the actions that they've taken to see these improvements include those pre-visit planning sessions where we try to proactively identify the patients that are coming in on the schedule. What needs will they have? So we're prepared for that visit when they come in. And as well as just changing up the way that they offer this vaccine to the patients and their family. So we started introducing this as a recommendation from the CDC rather than an option for the patient and their family to make that choice.
All right. there are no questions, we're gonna turn it over to Joe Presley, our ACO Medical Director.
Good morning, everybody. I'm Joel Presley. I am the Executive Director of Care Alliance, and also here to present with me is Jim O'Connor, our Population Health Analyst. And as Dr. Nixon and Jamie just discussed, we started our population health journey with our patient-centered medical homes, and once we were able to replicate that success, we started to wonder what was next. We were still a lot like many other organizations, even though we had some success in the value-based care arena. We asked ourselves, where do we go from here and how do we get there? We still face the same dilemma that many other organizations faced. What if we don't change at all and something magical just happens? We thought that waiting for something magical to happen was not a strategic plan. TIF Regional's leadership decided in 2015 to form Care Alliance, a Medicare Shared Savings accountable care organization. We began by asking ourselves some fundamental questions that we thought would help us on our journey to a better value-based care model. What resources will we need? How do we function in a fee-for-service model and push value-based care? What would be the barriers to our success? How will we sustain the change to value-based care? And what will the ROI be and how soon? What resources did we need? We needed startup funding. We needed money to hire consultants and for legal advising to complete the required CMS documents. We also needed staff. We needed care managers. Our ACO utilizes the same care managers that our patient-centered medical homes already have in place. Their work is beneficial to the PCMHs and our ACO. We also created 2 new positions, the Population Health Quality Coordinator and the Population Health Analyst. And that's actually Jamie's title that Mr. Richardson did mention, is she's actually our Population Health Quality Coordinator. So we kind of cross-pollinate with roles here. And we also utilize existing IT resources from our health system. We also needed a data analytics system that can integrate the CMS claims data that we get for our ACO and our electronic health record data into a common platform. Where do we focus? We focused heavily on quality improvement. We also focused heavily on preventative services like colon screenings, breast cancer screenings. Many of these can be accomplished in the Medicare annual wellness visit. We also focused on disease management and generated beneficiary lists of certain disease states for our care managers to assist with. We focused on our high-risk patients, many of whom account for a large portion of our healthcare spending. And we focused on high utilizers. These are the beneficiaries who have a high number of ED visits or readmissions. And we've actually decreased our readmission rate significantly through this effort. And we also focused a lot of attention on data management, and Jim's going to speak on that for a moment.
Thank you, Joe. Again, I'm Jim O'Connor, Population Health Analyst for TIF Regional and Care Alliance. I'm an IT geek that was sucked into the population health space about 4 months ago. And nobody told me I'd have to get up and speak like this in front of everybody. So bear with me as I'm kind of nervous.
You're doing good.
Thank you, sir. After the formation of Care Alliance, we realized that our EHR platform could not manage our data needs. With that, executive leadership committed $1.7 million towards the purchase of an integrated suite of population health solutions. Our goal was to deliver data-driven care through these solutions. So one of the biggest advantages our solutions provides is an intelligent way to aggregate and manage all of our data sources. So we're talking about EHRs, labs, radiology systems, payer claims, financial and pharmacy systems, immunization registries, and future information exchanges or HIEs. Our analytics solution slices and dices the enormous amount of data we receive through our intelligence platform and gives us opportunities in cost, utilization, and quality care gaps. And finally, the opportunities that we surface are delivered to our care coordinators, and they connect our providers, our patients, and our services across our medical system. So even with our population health solutions, we still see opportunities and challenges with our data management. First, we always have to ask ourselves, is the data current and is actionable for our providers and for our care coordinators? Secondly, with the huge amounts of healthcare data or big data available, we have to watch that we don't bury opportunities or create analysis paralysis. Lastly, there's a big need for IT resources with value-based care knowledge. Beyond our local challenges, we also see larger barriers to forming and sustaining an accountable care organization. I know we're all aware of the struggle between the fee-for-service and fee-for-value models that's out there in the organizations. There's still few rewards for providing quality care, reducing costs or utilizations under fee-for-service contracts. We also see the need for a top-down cultural shift towards fee-for-value like we've seen here at Tifton Regional, as well as enhanced funding opportunities and sources for human capital needs. The lack of interoperability or interconnectivity of technology systems, both locally and on a statewide basis, continues to challenge our data sharing. There are also great concerns over internet bandwidth for rural organizations and providers in Georgia. And I'll stop here and ask if there's any questions, and if not, I'll turn it back over to Joel. He'll highlight some of the ways we're going to maintain our current momentum.
Thank you, Jim. So how can we sustain our momentum? You know, we have a multi-layered approach to overcoming the known barriers Jim just talked about. We're obviously going to continue with our patient-centered medical home model. We consider that a building block to value-based care. We started with our patient-centered medical homes, and we've had momentum. We keep building on that momentum, and we're going to keep the recognition and keep building and adding clinics as we go. We're also going to continue to grow our care management program. You'll hear from Mary Perlis in a minute, and she's our outpatient case management director. And we've actually added staff continually to that department because it's becoming more and more and more of a need as we add populations to that. We're also going to continue to educate our clinicians and support staff. You know, I think nationally, statewide, sometimes even here locally, you know, there's a lot of lack of education on value-based care. What is it? The word means something different to every single person, you know, and educating those people down to your frontline staff, the impact that they can have on value-based care is important because that's across the spectrum of healthcare. And we also have very visionary and forward-thinking leadership. We're very thankful for Mr. Richardson, Dr. Guest, Chris Dorman. We've been very fortunate to have leadership that supported this effort, although in my next slide I'll talk about it. It's hard to show a return on investment in the beginning of value-based care. It's not an overnight sensation. There's a lot of people, we've talked in other places, and we've fielded a lot of questions about what we've done here locally, and everybody's like, what is your return on investment? That's really like the first question. You know, they don't really care what we did, they say, what is your return on investment? And so we've battled that, but we've continued that momentum and kept it building. We've been fortunate to have great leadership here to support us. We're also going to continue to utilize our data analytics, and we're going to continue to focus on our quality of care and our cost reduction. Two things that are obviously extremely vital to value-based care as we build our model and expand that model. And, you know, I've spoken just for a second about this, you know, but lastly, this is the most common question. When can you expect an ROI? That's what everybody wants to know. Doctors, you know, hospital systems, health systems, partnerships, you know, and so they all want to know this. And for us, you know, I think you know, the change of fee from service to fee for value, it's not overnight, it's long-term. It is a long-term investment. It really is. You know, and from our experience, you know, you really can't expect anything back for 18 to 24 months. Because we are in a Medicare Shared Savings Program ACO, we're a Track 1 ACO, but we won't even know how we did until September of this year, and we started in January of last year. So they don't even tell you what your results are for your quality or your cost reduction. So, you know, people want to see that ROI, but really that's 18 months down the road from CMS. And that's really hard. That's a big investment for people to put money in when you can't show a short-term, you know, return on investment. You know, and lastly, it's leadership. Like I spoke a minute ago, we have exceptional leadership here. You've got to have leaders who are going to lead you and allow the people like us to do the work and trust us that we're doing the best that we can. And, you know, and I think Jim spoke a minute ago about this. There's not a lot of education in rural Georgia for people, IT people, people like me and Jamie, you know, and really, you know, interesting enough, we're all self-taught. We've done the research. We read the final rule. When CMS puts something out, we go get it and pan through all those pages and what does it mean. And so we really spend a lot of time developing that, nurturing that locally. And now I'm going to turn it over to Valerie and Whitney, and they're going to talk a minute about social determinants of health. We were awarded an Accountable Health Communities grant, and so they're going to go into this more. It's a great grant. I think it's going to benefit us tremendously. It is a partnership with Medicaid, so I'll let them talk about this in just a second. And then,
Joel, before you leave, let me
Yeah.
ask you, not to put you on the spot, but
Sure.
anything you would share around high risk that you're doing here that's maybe innovative?
We've actually focused, we don't have a slide, but we did same-day visits and ED visits, and so we greatly reduced our ED visits to our patient-centered medical homes. We focused on those high utilizers, and we get them into our care coordination program, and we enroll them and we care manage them, and that reduces your ED visits. And Mary's going to talk at the very end about some rural challenges, and so I'd like for her to highlight some of that. But there is a great need, because in rural Georgia we have so many high-risk patients. And it's not just one thing, it's multiple things. It's not just comorbidities, it's social needs, it's mental health. So you can categorize high-risk patients in 1,000 ways if you really want to, but we have been able to reduce our ED utilization and our hospitalizations and our readmissions. So we're working hand in hand with our medical homes and our ACO to kind of drive that. So I hope I answered your question. And now I'd like for Whitney Lampkin and Valerie Levy to come up here and talk about our Accountable Health Communities grant.
Thank you so much, Joel. It's truly an honor to be here to tell you more about the grant we recently received. So on April 6th of this year, CMS awarded TIF Regional with the Accountable Health Communities grant. The total award is for $2.5 million, spanning over a 5-year period, and and TIF Regional Medical Center was one of 32 organizations in the nation to be awarded this grant, and we are the only organization in the Southeast. Now, before I move on to tell you more about the grant and what it's going to do, I think it's really important to highlight the significance of this achievement for TIF Regional, and for that I'm going to hand it over to Whitney Lampkin, who was the Accountable Health Communities grant proposal writer for TIF.
Thank you. Thank you, Valerie. I am Whitney Lampkin, writer of TIF Regional's Accountable Health Communities grant proposal. TIF secured this grant award having limited resources to assist with the grant proposal. During the application process, I was actually an employee of the patient-centered medical home department. Due to my limited experience, I did go out and purchase a few books to assist me with grant writing. Those books really helped me navigate the process, y'all. I can't even tell y'all how. I also received guidance from Pam Reynolds, who was the executive director of Southwest Georgia AHEC. What I find so significant about this is, unlike other hospitals, we received this award without any prior training or experience. However, we had to compete alongside those well-prepared hospitals having skilled grant writing teams. Just the process of applying for a grant is a learning experience in itself. Rural providers generally lack the know-how as it relates to applying for a grant or identifying those private and public sources to fund programs like the AHC. In my opinion, training and technical assistance would be very beneficial for rural providers to help them build capacity within their organizations and communities. At this time, I will turn it back over to Valerie, and she will talk about why we pursued the AHC and a few other programs activities. Thank you.
Thank you, Whitney. And you all, she is actually being very modest. When I was hired on and held that grant in my hands, I couldn't believe them when they told me that Whitney did this without any experience, and I had just gone to grad school for 2 years to learn how to do what she did in less than one. So very remarkable, and we really are appreciative for her. So what is the Accountable Health Communities model? Well, CMMI developed this model to assess whether or not addressing social needs can improve health outcomes and reduce utilization costs. So, as many of you probably know, the literature is suggesting that it's the socioeconomic factors or social determinants of health that have the greatest impact on health. And I think the CDC does a really great job of illustrating this concept with their health impact pyramid. And as you can see, the socioeconomic factors are placed at the base of the pyramid, while counseling and education and clinical interventions are placed at the top. And when I say socioeconomic factors, I mean factors such as poverty, low education, transportation barriers, etc. So why accountable health communities? Why do we pursue this? Well, as has been previously mentioned, in a rural community like Tifton, social needs are extremely high. And facing the effects of unmet social needs is something our practitioners do daily with their patients. And while addressing these social needs are often part of routine clinical care, we have limited resources, limited personnel, and limited time. So it's hard to place all of our focus on long-term social barriers when we have emergent health needs at hand. So this is why this grant is so special to us, because it's going to enable us to address the social needs for our community through social needs screening, community resource navigation, and connecting patients to existing resources in the community, and is also going to allow us to start collecting and tracking data, as well as enhance our clinical community partnerships. And as it's been said overall, our goal as an organization is to utilize all of our efforts, whether it's through our grant, through our ACO, or our PCMHs, to ultimately improve health outcomes and have a better community, healthier community. Thank you. And now I'm going to turn it back over to Mary Perlis, who is our outpatient care coordinator, or director of outpatient care coordination, and Dr. Cameron Nixon.
Our last slide, we just wanted to try to highlight what you're seeing the recurring themes of some of the challenges we're facing in rural healthcare. Some of the biggest things here is first the physician shortage. We all know that the physician shortage is going to affect everyone, including our state. It's terrible in the rural market, I have to say. We have a difficult time bringing in new physicians. Typically, we try to train or get you in AHEC or in our different programs to try to home grow you, and then so you'll be more willing to come back. The recent reports and studies show over 90% of people who train in metropolitan areas stay there. And so we're having a hard time recruiting. It goes beyond that. So if we don't have physicians, we move to our nurse practitioners. So we're moving our nurses to become nurse practitioners to try to take care of the needs of our community, which means there's a nurse practitioner shortage as well as a nursing shortage. And so those are some of the major challenges that we've been seeing in the rural healthcare market, and bringing in new physicians. Who's going to take care of me when I get old in here in Tifton? And that's the question we've been facing with those challenges. Others Mary's going to talk about.
Hey, good morning. You ask any care coordinator in the state of Georgia, probably these three things are going to follow. Where do we have our most difficult challenges? First being insufficient behavioral health services. When patients present to our ER, it is a laborious, painstaking process to get these patients the care that they need and deserve. Before we can even get the patient on what they call the Georgia Crisis Access Line board, you have to exhaust all other efforts, such as calling multiple psychiatric facilities to be denied before those patients can be placed on the board. Once they're placed on the board, then usually it takes around a couple of days to get these patients out of our ER into the care that they need in an inpatient facility. Now, if you're a complex medical patient, such as dialysis, patient with multiple wounds, pregnant patients, and or children, it can take weeks. Now, my question there is, have you ever thought about laying on an ER stretcher for a week in the same room? So, several years ago, we closed our state hospitals closed, along with our skilled nursing facility that's about 20 miles north of us that handled our severe mental health patients. They closed. And this has most definitely been a difficult reality. Now, transportation. If you live inside of Tiff County, you can access the TIF lift for about $3. Okay, if you're outside the city limits or in the surrounding counties, then most of our patients rely on cabs and ambulances. Now, if you happen to have transportation covered and can use the logistic care services, a lot of the times our patients are left. Those patients are left in our lobbies to wait with no food, no water, or a way to the bathroom. Another difficult reality. So, inadequate healthcare coverage. So you heard Dr. Nixon talk about patient GNR earlier. They were a great couple. Had the pleasure of working with them myself. patient G had one of the worst mouths I had seen in 27 years of nursing. It was bad, guys, it was bad. But anyway, due to having Medicare and Medicaid coverage, she has no access to dentists and or oral surgeon. So we were left to negotiate rates and set up payment plans for her and her mother together made less than $1,000 a month. So every day we face these challenges, and we're not alone, I know, but we do strive here to provide the best service we can for our patients, and we appreciate y'all's time and certainly appreciate any assistance that can come this way.
Thank you, Mayor. At this time, we'll just, if there are any questions from the panel that we can answer, please let us know. If not,
Senator Burke?
Thank you, Governor. Of course, I want to thank Bill and Bill, the folks that are hosting us here. I call them Bill Squared. And they've obviously done a great job with the meeting, but the care that they're delivering and the innovation that they brought to South Georgia is certainly appreciated by me. And when I put on my medical director hat from my facility, you know, I kind of drool with jealousy because of where I'd like for us to be. And I think I've seen a couple other hospital administrators from some smaller rural hospitals, and all of us are kind of drooling about some of the innovation that they brought forward. Dr. Nixon, you mentioned some of your resistance, being a fellow physician. We know that doctors kind of like to do things the way they've always done it. And I'm just curious as to what your secret sauce is to get those folks to kind of get in line behind you. Or do you turn around sometimes and think they're there and they're not?
I still look over my shoulder. The secret sauce is truly transparency. You know, and you know, as a physician, our calling is to, first do no harm. We want to help and promote health. I mean, that's the key. And knowing additional information that can improve the health of your patients, the health of your community. I mean, you'd be hard pressed to get any physician to turn their back on doing that. And just to see that. But the way the system's set up right now, you just don't get that data. You don't get it until it's too late. So how can you make any changes when it's 6 months old? And that person's already been admitted, that person's already gotten sick, and that person's already had that complication. And so being proactive and seeing real time makes a real difference for that. And that's what the secret sauce is.
And the outcomes that we have in South Georgia obviously are not very good in a lot of the more rural counties. I'm assuming that you think that if those physicians had the tools that you've got right now, that they could make a difference and improve those outcomes and therefore save money and perfect that triple aim that we all keep talking about?
Yes, sir. I'll give an example is just to get the idea that 75% of my diabetics had an A1C less than 80. If you asked me a year before, it would have been about 40%, like we were seeing other places. And what was the difference? The difference was access and spending time. It actually was not some secret medicine, high price, something different. It was actually educating and taking time to educate the patient about how to manage, become the patient center. They're managing, they're part of the team to manage their disease. And it makes a big difference. Once you get a patient there, they just keep getting better and better. And you just see that in your outcomes.
Thank you, and I want to say also thank you to our host. I was thinking back, I think I've been to TIF Regional 3 times over the last several years, and I just want to say the remarkable growth. I went over to the other building last night that you're putting up, and it's just phenomenal that what you're doing here in South Georgia, and I think y'all are a shining star, and we appreciate that. One of the things I wanted to bring up that this committee is going to be looking at, and I'm so glad that you brought it up and you recognize the importance of it, is data analytics. And the committee's going to be having a meeting about healthcare IT and infrastructure, data warehousing, integration, and navigation. And I think that is the wave of the future. and reducing cost is that analytics and predictability. And I'm so glad that y'all have someone on board that is doing that, because I think that the folks that do that initially are going to be steps ahead in this transformation of whatever direction healthcare goes in. So I encourage you to watch this committee, and I think you're going to see legislation and an emphasis in the appropriated budget on data analytics and predictability.
No other questions, we'll turn it over to the TIP team. I mean, Emory team.
The Emory University team, I think, is ready for us. Dr. Greg Abser, Dr. Elizabeth Krupinski, along with Dr. Bill Tifton and Cheryl Littleson. So pleasure to have each of you here today as well.
Thank goodness.
It happened for several reasons. Lieutenant Governor Cagle and the Senators, thank you for the invitation to participate today for the Healthcare Reform Task Force. We appreciate the opportunity to be here. Mr. Richardson, Dr. Guest, thank you for your hospitality, and all members of TIF Regional, we appreciate it. This is our second time down here, and we're very grateful for your hospitality coming from the north. I bring to you a message from our CEO of Emory Healthcare, John Lewin. He's our Executive Vice President for Health Affairs and the Chairman of the Board for the Woodruff Health Sciences Center. Dr. Lewin says that we recognize the challenges that many patients and their families face in accessing and paying for medical care at the right time and the right place, and we are committed to working with our leaders in Georgia and beyond to solving these problems. We look forward to working with our state legislators to make virtual patient care more accessible by enacting laws that make delivery of virtual care easier, more efficient, and affordable. Our agenda today is to give you 3 short presentations. The first on electronic or e-ICU at Emory, and how can the e-ICU program help Georgians. That will be given by one member of who I call the dynamic duo, Cheryl Hiddleston, one of our the nurse leader for the e-ICU, on behalf of her and Tim Buckman, the physician champion for e-ICU, and many other things. Secondly, we will look to Dr. Elizabeth Krupinski, who's our Vice Chair of Research for Radiology and former President of the American Telemedicine Association, who helped spur Arizona's statewide telehealth network model. And we will look at that as a potential roadmap for Georgia and how we can implement that here. And then thirdly, I will talk to you about virtual patient care at Emory and helping Georgia towards a healthier people and a healthier economy. Thank you. Cheryl?
Good morning. I usually have problems with slides. Hopefully they'll all go in the right direction. Yay. So I am the director of the Emory e-ICU program, but I have been a registered nurse in Georgia for 33 years. For 26 of those, my focus has primarily been on critical care or patients in the intensive care environment. I'm going to talk for a few minutes today about how Emory has achieved the triple aim of better health, better experience of care, and lower costs for our most vulnerable patients, those who are critically ill in the intensive care areas. As you have heard a little bit this morning, we have an aging population. 10,000 Americans turn 65 every day in this country. In Georgia, we feel that also. Over the next 8 years, there will be a 39% increase in the population in the age group of 65 and older. You'll see that that is more than all of the other combined age groups together. In addition to that, as we get older, 65 and older, and you'll see especially for those adults 85 and over, the demand for critical care services from critical care physicians or intensivists and nurses specializing in critical care is growing. The supply
is not meeting the demand. And it looks as though that gap will continue to widen over the next several years. So we were trying to find a solution to make sure the patients have the right care. This is a picture of our EICU area. We're located in Dunwoody, Georgia. We monitor patients in 5 hospitals, 11 ICUs, and 132 beds across Georgia. We have critical care nurses who are experienced in critical care at the bedside who work 24/7. We also have intensivists, those specially cared physicians in critical care, and they work nights, weekends, and holidays when we don't necessarily have people at the bedside in the hospitals where we work. For the colleagues at the bedside, we partner with the hospitals and we help alert them when we see something happening with a patient. We advise them on how they can move forward in providing the care. We mentor them when they have questions or there's an education gap and they need help on that. We also consult with on-site physicians and staff to provide the care they need. For the patients, we of course order tests, treatments, we help interpret those, and then we help the bedside team decide on where to go from there, and then we evaluate how things have turned out and we continue to follow the patients. This is an example of what our area looks like. It's a very high-tech area. We run a lot of applications. We are the land of big data. But the thing that I really want to point out is even though we have all this data, and it does allow us to see when a patient is veering off trajectory, and the bedside may not see it because our displays are novel, this is really about the people. It's about the clinicians and it's about the patients. We consider ourselves safety officers. We're there to make sure and help the bedside team to ensure the safety and quality of the care their patients are receiving. This is a map, the first map, the blue one, is a map of the southeastern United States. The stars are actually EICU hubs in the southeast. You'll note that there is one in Georgia, and that is Emory, none in Mississippi, none in South Carolina. In Florida, they only have hubs in the middle and lower portion, and even in Tennessee, there are none on the eastern side. So the demands for our services are growing. The other map, the green one, you'll see there are little check marks that represent the hospitals that Emory is currently providing services for around the state. The other marks are where we have had different hospitals come to us and discuss providing services for them, again, in several different regions of the state. Right now, does this pointer work? Yep. Oh, I can do it here, can't I? Sorry. Right here, you'll note, oh, it's not working there. Sorry. So on the right-hand side of the state, right next to the word Georgia, is Statesboro. It's about 40 miles north of Savannah. We provide services for East Georgia Regional Medical Center in Statesboro, which is not an Emory-affiliated hospital. We went live with East Georgia 3 years ago, almost 3 years ago, in August of 2014. We partnered with them because they have a lack of critical care doctors there. They actually have one, and he's running around trying to take care of all the patients and manage everything that he can. So they asked us to come and partner with them to provide services to their patients. There was a big media storm. A lot of patients came and visited while we were there when we went live. On the far side of the screen, you'll see a camera, a monitor. We have cameras, monitors, speakers, and mics in all of the patients' rooms, and it allows us to have bi-directional communication with all the patients, the staff members, and the families in the rooms. They were very excited when we went down because they couldn't believe they were going to have access to specialty physicians and nurses without having to leave their hospital. They could stay in their local hospital, get the treatment they needed, but they wouldn't have to leave their families. These are some outcomes that we found pre and post intervention with the EICU at East Georgia. In the first 4 months of our program, their mortality rate dropped 54%. The transfers from their ICU to outside hospitals dropped 30%. Their daily census, the number of patients they had every day, went up 41%. And they had some other changes that showed that the patients they were taking care of were actually sicker because they were able to keep those patients with an increased level of expertise to help to provide the care. Their length of stay went down in the unit and the hospital, and patient days per month increased, which means they were able to get more patients through their critical care area. Our program started with a Healthcare Innovation Award from CMS. There were $1 billion on the table and 3,000 applications were written. Dr. Buckman actually happened to write one. And the only award in Georgia was provided to Emory for this program. So along with that came a requirement that CMS would appoint an independent auditor to follow our patients and come up with a report, which they did. So in this model, you'll see that there are different results. A patient episode here was the length of the hospitalization of each patient, plus they followed them 60 days post-discharge. What they found was republished in March of this year, and these are the results. Overall, our patients were compared to 9 hospitals in the region. So they didn't just look at our patients, they looked at other patients in other hospitals. We had a reduction of mortality. More patients were sent home. Instead of going to LTAC or skilled nursing facilities, they went home. So patients were being discharged healthier. There was a reduction of the 60-day readmission rates, which represents better health. The better experience of care was shown by a reduction of the length of stay and improved access for these patients. They didn't have to be put on an ambulance and sent 200 or 300 miles away to receive the care that they needed. And CMS also sent out surveys to all the patients and families post-discharge. And our family and patient surveys actually had more favorable results. And we also lowered cost. They found that for the Emory EICU patients, there was a reduction of $486 per patient episode. Over, what did I say? Oh, $1,486, sorry, per patient episode. Since we began 3 years ago, we have seen 24,000 patients. This is an estimated savings of $33.6 million while serving the sickest patients in Georgia. Thank you. I think Lizzie's next. Dr.
Let me ask you a question real quick.
Yes.
In terms of barrier to entry, what kind of cost are we looking at for other hospitals that might be able to take advantage of this?
So the cost is not small. The primary cost for this is the initial installation and purchase of the equipment that goes in the rooms that you saw. The company that is developing the equipment is actually working on a new model, which is more of a leasing model, so there's not the big outlay up front. The other cost associated with it actually is our facilities costs for the physicians and nurses who provide the services. And right now, we get 63% of our patients are Medicare patients. 10% are Medicaid patients. There is no reimbursement at all for those patients. We do file insurance for our patients that have private payers, and we get a very small, what do you think the percentage is? 15% reimbursement on that particular patient population. So the majority of the cost for running the program lies with Emory and the outside facilities right now. You're welcome.
Thank you and good morning, everyone. For the opportunity to be here. What I want to do is talk a little bit about how Arizona can serve as a model of telehealth. And tele-ICU, the EICU, is just one example of telehealth and the opportunities that are available through telehealth. Now, why am I speaking about Arizona? Well, I've been at Emory since September of 2015, but I've been involved with telemedicine since about 1994 when I started in the state of Arizona. And I was there for 23 years as part of the telehealth programs there. And I think there's a lot of similarities between the two states. and to show a little bit about what those opportunities and similarities can lead to. This is an example or a map of the state of Arizona and the telemedicine networks that exist there. And there's a number of networks, and it's very similar to Georgia to some extent. There's like 3 or 4 main urban areas, and then everything else is absolutely rural. Tucson, Phoenix, Flagstaff, and I put Tuba City on there because that is the heart of the Navajo Nation, and that is one of the key places in northern Arizona that we made a huge impact on. Prior to having telemedicine, they really had nothing. We literally had to lay the lines down to get them not only network but electricity to run the networks. And all of that ended up benefiting the community immensely. But what I'd like to point out in this slide is the fact that all these little clouds and all these little lines represent a variety of telehealth networks in the state of Arizona, and how through a lot of key efforts developed a partnership model throughout the state and joined up all these variety of networks to cooperate with each other to reduce a lot of the redundancy that we saw in programs that were being offered, as well as to enhance healthcare through telehealth. And what I mean by some of the redundancy is, for example, we polled who was doing diabetic retinopathy screening, and we found that there were 29 different organizations around the state dealing with diabetes and trying to reach out and provide care to diabetic patients, and a lot of redundancy. And by joining efforts and finding out what everybody's doing and what patients were being served, we were able to reduce the cost of those services and actually make them more accessible to more people. So what's common between Arizona and Georgia? An awful lot. The states look very similar to me, to be perfectly honest, and both were very early adopters of telemedicine. Here in Georgia, Jay Sanders from the Medical College of Georgia is one of the earliest adopters of telehealth, actually back in 1991, but in 1993 at the Medical College of Georgia, he established the first statewide telehealth network here in Georgia. And in Arizona in 1996, actually going back to 94, Dr. Ron Weinstein developed the Arizona telemedicine program. And they were actually residents together, and you get them in the same room, one or both of them invented telemedicine. It's kind of like Al Gore. Neither of them really did. It's been around a lot longer than either one of them, but they do have certain claims to fame, and they really initiated the 2 states. The drivers in both states for telehealth have been they're very rural, very dispersed geographically, with very disparate patient populations, large minority populations, large medically underserved, provider shortages with a maldistribution, as we heard from the Tifton presentation, and major healthcare issues. Diabetes is just one of them, but telemental and behavioral health is just another huge example of the similarities between the states. Both of the states currently have a number of statewide networks, multiple programs that are doing telehealth, but not really partnering and communicating with each other. There's hospital-based, academic, the Department of Corrections, school, home, work, Department of Public Health, and so on. There's a lot of people doing telehealth that aren't aware of what everybody else is doing and really aren't partnering in the most effective way sometimes. We are also both hub sites for HRSA-funded telehealth resource centers. Raymond Brewer right over there heads the Southeast Telehealth Resource Center, and I was the PI on the Southwest Telehealth Resource Center. There's 14 of these around the country, each one funded by HRSA, to promote and help develop telehealth in the states. And both of them are highly involved in the states they're involved with, covering regional. And I believe we have someone from Iowa who is one of the 14, but is involved with the research arm of the HRSA-funded telehealth programs. We also both have strong state support for telehealth and telemedicine initiatives. The basic goal overall is to keep patients in their home communities with local providers. Now, one thing that we did in Arizona, which is where sort of an idea could perhaps arise for activities here in Georgia is we developed the Arizona Telemedicine Council. It was created by the state Joint Legislative Budget Committee in 1996 at the exact same time when they were starting to fund telehealth programs throughout the state and putting telehealth as line items in the state budget to fund programs. So it was a committee of the Arizona State Legislature. Originally, the main focus was the Arizona Telemedicine Program, but now it is statewide, and all organizations of any sort doing telehealth in the state are welcome. We meet quarterly in Phoenix at the Joint Legislative Budget Committee building, neutral territory for all the different programs. The goal is basically to educate and inform stakeholders about telehealth activities throughout the state and to build partnerships to help people expand services, reduce redundancy, as I noted, and efficiency. And when I talk about stakeholders, I am not only talking about government representatives, just a whole variety, including patients. They are open to the public and anyone can attend if you can find parking. But that's another problem in any capital city. I just want to talk about who the members are and who we have representatives from. On the government side, the main person who helped back in 1996 establish everything was Bob Burns, who was a state senator at the time and is now the chair of the Arizona Corporation Commission. But these are the key districts that are represented with our senators, all of them representing very rural districts throughout the state. This changes over time. We like to have people on like about a 2 to 3 year service on the committee, and then they rotate off, and representatives from different parts of the state rotate on. So that's the current slate of governmental representatives. Bob Burns has attended every single meeting since 1996, except for one, when his daughter was graduating, so he kind of had to come back. But otherwise, again, these people really, they take time out of their schedules to come to this meeting. Agency members, as you can see, we have the regional Board of Health there, we have the University of Arizona there, we have the Arizona Health Care Cost Containment System, that's our Medicaid, that's access. Different organizations, Cobra Valley Regional Medical Center, the Rural Telecom Congress is there, a whole variety of organizations and agencies from around the state are present. We also have educational members from the University of Arizona, as well as the Orthopedic Institute in Arizona, the College of Medicine up in Phoenix, our pharmacy. We often have our law school attend, surprisingly, comes to the meeting. So we have a whole variety of educational members, because as we said, a lot of what telemedicine is all about is training the next generation and letting them understand that telehealth is not a different specialty, it is not something different, it is simply a new way of providing healthcare through the use of technology and telecommunications. A lot of public members that are very involved in the telehealth community, for example, the president and CEO of Global Med, a company now that actually Jay Sanders is associated with and provides a lot of telemedicine technology throughout the country. We have folks from the Mayo Clinic, Copper Queen, law offices, our Healthy Connection, which is our IHE branch of the Arizona government, Alara Health, Carondelet Health Network, and so on. And then we have a variety of ex officio members who have been with us since 1996 but have rotated off, yet insist upon coming back to the meeting every single time because of the values that it provides to them. So, you know, what one possibility would be is to develop a Georgia Telemedicine Council. There are a lot of telehealth initiatives around the state. It would help us inventory and assess what the various resources and initiatives that we have, develop new partnerships throughout the state, and extend the existing partnerships that have already been developed. It would help liaise with various government representatives, increase awareness both on the local and the national level, and address a number of policy issues that is facing healthcare in general that we believe can be addressed through telehealth and telemedicine initiatives. So with that, I'll hand it over to Greg, who is going to talk about what Emory can bring to Georgia, if there's no questions.
Thank you, Elizabeth.
So you've heard about a care model, an electronic ICU. You've heard about opportunities for our state to organize around telehealth. And so one of the questions is, what can Emory bring to Georgians through virtual patient care? And I think one of the questions is, why do we say virtual patient care rather than telehealth? It's about care, and it's not about tele. And you heard a little bit about that from Elizabeth, but it's really about how do we take our seasoned faculty, our clinicians that do work every day to facilitate the best clinical care, and have them do discovery and innovation so we can make care better and make sure that we are educating the next generation. This is the tripartite mission that we hold dear to our heart here at Emory. And we want to bring to Georgia. So, and we are kind of starting within our own group, talking about what can Emory do for Georgia, Emory for Georgia. And that is in a very collaborative sense with those who are already doing a lot of excellent work, not only at Tifton but in other parts of the state. We want to be collaborators with you. What I'm going to talk to you about are what we have done and what we will be doing in telehealth. Up in the right corner is Mike Frankel. Mike has been at the center of the two major clinical discoveries in stroke, the clot-busting drug IVTPA, and then most recently thrombectomy, which is the extraction of clots from arteries that cause stroke. And Mike has been at the center of those. And he is a visionary clinician and researcher, and he is about to start the Marcus Stroke Network project, which is, I would call, Telestroke 2.0. This is a 2-year project funded by the Marcus Foundation. It's a $15 million project that has partnerships with Grady, the American Heart Association, and Emory Healthcare, amongst others, including hospitals that we will be partnering with. And what this will do is take stroke and not just look at it from the telestroke perspective, which is what most people think about, which Tifton Regional, for instance, is already very well versed in. It's not just about what happens in the emergency room. It takes stroke care from what happens in the field all the way to what's happening in the hospital and beyond. And that looks like, how do our EMS folks do field triage? What apps are they using? How are they potentially connected through mobile stroke units with CT scanners, which exist today in Houston and in Seattle? How do we get a patient from an ambulance to the angio suite to get that clot out of their artery by bypassing the ER? How do we do that? Because time saves brain. And how do we use the American Heart Association platform to make sure that hospitals are adequately prepared to deliver the care for stroke patients throughout the region in a standardized way so that the patients can get the best quality care? Why? Because early intervention reduces mortality and disability. That contributes to a reduced healthcare burden and continued independence. Patients can work, patients can contribute from a personal perspective and remain independent and viable in their communities. Let's transition. Which one of these lesions that you see on this patient are cancer? They look the same. The patient may be worried about it. He doesn't know. Spot just came up. Maybe he goes to his primary care physician and he says to his primary care physician, which one of these is cancerous? And the primary care physician says, well, we really don't have access for dermatology. Like in some regions of the state, 6 months to see a dermatologist. Dr. Sufi Chen knows that. And Dr. Chen has been a champion with others for teledermatology. I'm going to show you 3 program examples. Dr. Chen at the VA instituted a teledermatology program, which is a store and forward system. In other words, a picture is taken. It is then sent to Dr. Chen and her colleagues. Dr. Chen reads it. Is this a lesion or a rash that we are concerned about? Funnels back a report, says, you know what, you need to come for a biopsy, or hey, you know what, apply a cream. In FY16, 4,700 consults done at the VA through Atlanta VA. 1 business day turnaround for store and forward. Some were rashes, some were lesions. About 480 lesions per quarter. 40% of those lesions required biopsy, in-person visit for dermatology, 47% skin cancer diagnosis, 4% melanoma. Melanoma, very concerning. Why? Because it causes significant morbidity and mortality. This work led her to get a grant from the Office of Rural Health for expanding the program to other VAs and beyond. This is a potential program that could help Georgians tremendously, especially in the high melanoma areas. Another pilot led by the Department of Public Health, extraordinary leadership from the Department of Public Health to initiate this pilot, and already what they're doing for telehealth throughout the state. The Department of Public Health partnered with Emory as well as employers like me in a pilot to look at how do we take businesses who have employees and actually get them screened if they're at risk for skin diseases. In 2 days in April 2016, 44 persons from 2 organizations, Langdale Industries and the Lowndes County government, were screened in real time. They were screened in their community. A lesion was identified and it was sent to Dr. Chen and colleagues. That lesion was read and real-time advice was actually given to that patient. And that showed 12 patients that actually had suspicious lesions and were referred for biopsy and follow-up. Over 2 days, 44 patients, 12 biopsies. Very important care model that needs to be refined, but certainly a successful pilot led by the Department of Public Health. And a third, how do you actually take care of patients in a hospital when there isn't a dermatologist but there's a skin disease? At Emory University Hospital Midtown, we lost our access to our dermatologist. We had to institute a program. Dr. Chen put in a store and forward program where if there was a skin lesion, a picture could be taken, forwarded to them for interpretation and then subsequent result. The preliminary data shows that you save 1 day of hospitalization for a patient with a skin infection, otherwise known as cellulitis. These efficiencies can create tremendous quality of care and reduction in costs over time. Now, I'll ask you, what's in a pair of glasses? How many glasses do we have in this room? Contacts, glasses? I have contacts. Look at this. What's in a pair of glasses? I can actually see. Dr. April Ma knows that glasses help people see. She also knows that there is a tremendous burden of disease for people that can't actually see or have eye diseases that threaten their vision, or that they just need glasses. So she, again through the VA, developed a comprehensive eye screening program in primary care clinics serving medical underserved communities, including the rural, homeless, and indigent populations. Look to the picture below Dr. Ma. This is a setup in a primary care office. And what happens here is there is a technician that goes to the primary care office, does a screening for a patient, identifies whether or not they have a refractive error, that they need glasses, or whether that they have other eye disease. This was implemented throughout the VA system, 6,000 patients served in a year, greater than 90% in less than 14 days. Glasses were made for a tremendous number of folks, and diseases were identified: glaucoma, macular degeneration, diabetic retinopathy, all which threaten vision and have treatments. A large population of homeless patients were served, as well as 50% rural veterans. Patient satisfaction very high, no-show rate, because it was in the primary care office, very low. And it has been expanded to a regional program as recently as May 2017 for the VA. On the same tele-ophthalmology theme, Dr. Yusuf Khalifa at Grady Health System also recognized diabetic retinopathy, threatening vision, as a major problem for Georgia and specifically at Grady. These are the Georgia numbers as of a report in 2011. About 20% of Georgia adult diabetics, which is about 155,000 people, were told that they had diabetic retinopathy. This is not a small diagnosis. Diabetic retinopathy threatens vision. In other words, these people, if untreated, could go blind. Dr. Khalifa created a partnership between the ophthalmologists at Grady, the primary care physicians at Grady, and the Intelligent Retinal Imaging System group with their camera, and they centered it around the patient and the family. And the patient and the family, we believe, are collaborators in these initiatives. What was the intervention? From January of 2017 to the end of April 2017, they did screenings. And the screening looks like this. There's a technician in the office, a patient sits at a camera, it takes about 30 seconds to a minute. Some of you have probably had this done already. A normal retina is on your left. You've got the macula in the center where a lot of the color vision comes from, and you have the optic nerve in yellow on the right. A diabetic retina is on the other side. What do you see in the diabetic retina?
Hey, good test there.
This is the diabetic retina right here. What do you see? You see protein exudates around the macula. You see flame hemorrhages in the middle of the retina. All of these threatening vision tremendously. This patient is about to go blind, or is blind in that eye. So what happens is they actually identify that, they generate a report, and they give recommendations to the physician. In those patients, you can actually identify and risk stratify the patients that actually need to come to the ophthalmologist for treatment. What was the result of his work initially? In just about 5 months, 2,000 patients screened, 828 patients actually had pathology, 533 of which had diabetic retinopathy. That's 25 to 26% of patients that had diabetic retinopathy, and if you look at the data further, 3% of them had proliferative diabetic retinopathy, which means 60 patients out of that 2,000 were about to go blind. They were caught, and they could receive treatment through Dr. Khalifa in the ophthalmology department at Grady. Just because we're Emory, we don't, sometimes we think we know everything, but we don't. We are a learning institution. We have to learn from others, and we need to have that humility. And so what we did was we went to the University of Mississippi Medical Center, which is a leader in telehealth. They've been around since 2002, and they've been developing over time. And they did a pilot with the diabetes program, or with Medicaid, to look at diabetics. Location, Mississippi Delta. In the Mississippi Delta, one of the poorest regions in Mississippi. The problem, diabetes. 12% of about 450,000 people have diabetes. Almost 300 patients died directly from complications of diabetes. The expenditures just in that area, $2.7 billion. The partnership, the governor's office, General Electric, Care Innovation, C-Spire, and North Sunflower Medical Center, all again centered around the patient and the family to provide the intervention. The intervention was in 109 patients' virtual patient care. The patients were trained how to take their blood sugar. They got remote patient monitoring. There was video chat enabled for education and care to be given by nurse care coordinators. Notice there's a trend, and there's common ground here with a lot of things you've already heard today. And there was local provider involvement when necessary. The result, 9,000 miles of travel saved, 96% medication adherence, no diabetes-related ER visits in these 109 patients, no diabetes mellitus hospitalizations, 9% diabetes patients with retinopathy identified and got treatment, and a projected Medicaid savings when you extrapolate for the population of approximately $200 million. With that, legislators made Medicaid, they made remote patient monitoring in this program allowed to be paid for and reimbursed to the providers that are actually doing this. So this brings up the question for our Healthcare Reform Task Force. What are our challenges and what are our opportunities? The numbers. There are too few experts for Georgia's growing population. And so we have to enable through education nurse practitioners and physician assistants that are remotely supervised by Georgia licensed experts, very much like the model that you saw with EICU. And as a destination state for aging, we have to do this to meet the increasing demand for immediate access. If we don't have fiber and cable somewhere, we need to lay it down. We heard about the challenges in Arizona. If those challenges exist in Arizona, we need to make those priority here to be able to deliver these services. Time. It's hard to staff during unsocial hours and highly specialized positions to do this. How do we attract professionals to Georgia? What are the things that we can do that actually bring the talent to Georgia? Are there special things that we can potentially do to that? Dr. Buckman and team are already the leaders in turning night into day by an innovative collaboration with Perth in Australia to actually deliver EICU care from Australia to Georgia in this model. And hopefully folks will get a chance to talk to him about that. How do we leverage partnerships and affiliations to bring expertise directly to the bedside and enact solutions that keep patients local with local experts and allow hospitals to thrive and support their communities? We need to look at where we have reimbursement challenges, store and forward teledermatology. How do we get remote patient monitoring services funded? How do we show that it works and then get it funded for diabetics and others? Heart failure patients, a big drain on the economy, and for patients that actually have them, how do we keep them functional over time? One of the questions is, can we remove the Medicaid telemedicine non-covered services looking with video as a cell phone? So if video is done on certain things like FaceTime, which is actually potentially HIPAA compliant, how do you actually enable the provider and the patient to actually talk in that regard very simply, very easily? That's not to say we're going to neglect the other modalities that others have in place, but for certain things, is that the modality that makes sense, and what do we do about that? How do we consider payment for services regardless of originating sites, such as in Vermont? Vermont has created a law that the originating site can actually be the patient's home. Wouldn't patients rather dial in from home where it's more private to actually receive care? Right now, in Georgia, it requires an originating site. How can we follow Vermont's model? And one of the questions is, and we're going to have to face it, there are these folks out there that are advocating for interstate medical licensure compacts and also interstate nurse licensure compacts. It's a contentious issue. I don't think we can ignore it. I think we have to address it. The question is, what do we do about it, and how do we figure it out? I think we need leadership on that to help figure that out. And I think we need to consider certain exceptions to Georgia Medical Board restrictions on telemedicine medication prescribing, because there are restrictions in place for dangerous drugs. There are restrictions in place for things like controlled substances that, frankly, psychiatrists need to be able to use in order to manage their patients from afar. And we're looking at that right now as we look at our own potential telepsychiatry programs. So these are a few challenges and suggestions and recommendations that we can think about. We believe that Georgia can lead the nation combining high tech with high touch. By leveraging telehealth, we can expand this new industry, generate new professional employment, work to solve access to care and high costs of care. We at Emory are committed to working as partners with all of you to provide the right care right now at every time and every patient, if it's possible. And with that, we invite questions. I'll invite panelists to come up for any questions that you guys may have for us. And we thank you for the opportunity.
Any questions of the panel? Let me just say that one, I think when you look at all the issues that you just outlined and the return on the investment that's been demonstrated, these are great suggestions and ideas for the task force that we can get busy on. So thank you, and thank you for being a leader in this space.
It is our pleasure. Thank you.
Okay, our next presenter is Keith Wheeler, who is here with us. Keith is Director of the Rural Policy Research Institute Center for Rural Health Policies, and we appreciate him traveling so far. I think he actually got in at 12:30 last night and is into Atlanta and now here with us today, so we appreciate you traveling so far.
My pleasure, and let me just say wow to the previous presenters. The activities you have underway, the innovations you're doing are just fantastic, and it would be great if we could replicate those rapidly, not just in Georgia, but in other places. My task is to bring us a little bit to a more general level of how one thinks about designing and building a sustainable healthcare system, sprinkled with examples, including the ones that you just heard. To design and build a system requires being purposeful with strategic change. Having a vision, where do we want to get to? Taking immediate actions as necessary, and you'll see some of those related to what is going on in Georgia and in other states right now with rural hospitals facing closure and many having already closed. Developing a plan while you're still having to address some of those immediate needs, and then taking actions based on that plan to achieve, again, the vision. I'll share a vision that comes from a panel of experts in rural health that I have had the pleasure of sharing for the last 20 years, as we developed about 7 years ago now a model for a high-performance rural health system. And we envision a system that's affordable and accessible through a sustainable health system that delivers high-quality, high-value services. That's informed by the needs of each unique rural community that leads toward greater community health and well-being. That vision has 5 specific foundations. A high-performance system is affordable, and affordability means not just to the individuals purchasing care, but to the society that's supporting that system. It's accessible. It's based around community health, so it is focused locally, with higher quality care, consistently trying to move that bar and with continuous quality improvement. And we've often used, and you heard it today with patient-centered medical homes, the term patient-centered. You'll see me modifying that now to say person-centered. And I pause for a moment to say that's intentional. If the focus is on health, both of me as a person and us as a community, the focus is not on us only when we are the typical clinical patient. The focus is on us totally as persons, not patients. If we translate those 5 foundations or pillars then into what does a local system and how is it organized? What does it look like? How is it organized? And you'll notice at the core of that system is primary care. And primary care here is more broadly defined, more consistent with patient-centered medical home, and even beyond that to what I call person-centered medical home. You've already heard about examples of that, like transportation as part of what we think about when we think about primary care services and the core of what should be available in every community. Social services, public health, and then, of course, the typical that we would always think of: primary care, dental care, behavioral care, urgent care, all of those as part of the core, then supported by or integrated with, is a better way of phrasing this, the other services you see in the next concentric circle out. And then all of that being integrated. And for the system to be totally integrated, there are a couple of points that I'll emphasize here in these few minutes. One of those is, again, something you've heard a little bit about already, the integrated health information that needs to be there to support care for us wherever we are in the continuum of care. And that may be in a local office, it may be in a regional facility, it may be in a centralized quaternary care facility if we're undergoing procedures that take place there. We need payment systems that are value-driven. You've heard that term already this morning. And we need collaborative relationships, both within our typical thinking about the clinical care system, but more importantly, broadening that out. And you saw that with the accountable healthcare communities example a few minutes ago. Well, what are some of these are the essential elements. Value-driven payment. So we've got to be about the business of changing payments so that the people we're expecting to achieve a lot of what you've heard about this morning have the resources available to do it without having to be driven exclusively by in a revenue model, let's chase the next unit of service. You heard Dr. Nixon talk about that, the churning, what oftentimes in loose, more layman's language, we talk about churning patients through. Well, if that's your source of revenue, how do you take the time and effort to do some of the more creative things that keep people healthy? If we change the source of revenue so that we take some of the $3 trillion that we currently spend in that clinically driven healthcare system and start spending some of that a little bit differently, maybe making it available through payment categories, you'll hear about this in a couple minutes, systems like global budgeting, per capita payment, something that gets, and one of my colleagues in healthcare delivery system world talks about, I need to get closer to the premium dollar in the context of health insurance. I need to capture some of that initial revenue that's coming in for the healthcare delivery so that I can spend it differently where the rubber meets the road and I'm trying to provide these services. That's what value-based payment and value-driven payment is about. The integrated health information and integrated governance is the notion of bringing together not just the typical players, again in delivering clinical services like the institution we're sitting in today, but again to use them as an example, bring to the table the other organizations involved in the community. You saw on the slide United Way. I recognize that immediately. Okay, bring them to the table because you've got to broaden the notion of what we do in service delivery. Well, that's all well and good, but in a lot of places, fortunately not the one we're sitting in right now, we have a more immediate crisis or cause for action. And that comes out of the unintended consequences of constraining ourselves and how we work toward remedies. That we've designed payment systems to try to maintain points of access. And that's a long-winded way of getting around to talking about cost-based reimbursement and critical access hospitals that exist in many rural communities here in Georgia and around the country. I'm from the state that has the most critical access hospitals of any state. We have 85 critical access hospitals in the state of Iowa. It's difficult for them to continue to sustain their services if you're asking them to transition out of that cost-based model, which covers a lot of their fixed costs, into something different. We've already had, since 2010, the numbers vary by whose count you're using, between 78 and 81 rural hospitals closed around the country, 7 here in Georgia. Texas is the leader. They've had something like 14 closed since 2010. We have another anywhere, again, depending on whose numbers, 280 to 700 around the country that are vulnerable for closure. Well, how do we work to sustain their services through the transition to a more sustainable system with payment change and the other changes that we're talking about? We can use some temporary payment adjustments and short-term grants as a way of doing that. And that's something that's under consideration even in some of the reform legislation nationally, and several states have looked at doing that. And doing so, though, in the context of we want to move toward that greater vision. We're not putting a finger in the dike to put a finger in the dike, nor are we trying to prop up the system that we've always had. What we're trying to do is sustain points of access while we transition to a better system. I too am a fan of using the word transformation instead of the word reform, because that's really what we're about. Well, how does one do that? So if you think about the current crisis of hospital closures, and we had a paper come out that's on the RUPRI.org website recently from the health panel, looking at this question of what do you do in communities where the hospital just closed, or there's a hospital about to close, and we have to do something right now. We can't wait for the next strategic planning and exercise to complete. Well, to do that, different ideas that I've pulled here. One is to focus on the core services, going back to that diagram. What do you really need in the community? In Douglas, Arizona, where the hospital closed, they worked with a nearby hospital and maintained in Douglas urgent care and an emergency department. So they maintained the services that are in that inner core. Sheboygan, Michigan maintained a 24/7 emergency room and expanded some services around that. Adult and pediatric primary care, imaging, laboratory services. They created a sleep center because that met the needs of the community. Rehabilitation services, and an outpatient surgery clinic. In both of those first two examples, there's no longer an inpatient hospital in that community as we know it. That closed. The definition of hospital closure that we use in the literature is you've lost the inpatient care. You haven't lost the facility, you haven't lost everything else, you've lost inpatient care. Importantly, that third bullet is a more general point of engaging the community in whatever the response is to either an emerging closure or a closure that's already happened. Final point of emphasis, note, those actions are consistent with that longer-term vision. That's the point I wanted to make. Well, how do you engage the community? There is no single model for reconfiguring rural hospital systems after closure. This is coming out of the paper that I mentioned the panel just finished. Local assets, affiliations, and partnerships, and financial and delivery flexibility and capacities must be critically assessed to determine the community's options and strategies. It's not a one-size-fits-all, it's a community by community. What do you consider when you're forced to redesign because of closure or other crisis? Well, one is an assessment of the available hospital and community assets so you can judge what is our capacity, what do we have available as we think about how to redesign the system here locally. Identify resource development opportunities. You saw a couple of grant programs mentioned in the earlier slides. Determine service development strategies and deploy the healthcare resources accordingly. So what do we need to be doing in developing a system that is sustainable? How do we deploy those resources we identified in the first bullet? And then identify and understand the impact of financing resources and liabilities. That includes, for example, the use of private foundations and what they might be able to do, an organization like the Georgia Health Foundation here in this state. It includes looking at other donors, at public resources that might be available. Again, you saw the use of grant programs in the earlier examples this morning. There are some current and proposed options for situations where hospitals have closed or are threatened to close. One of those is reliance on rural health, not reliance on, but use of rural health clinics, which is another designation in the payment world that helps sustain a point of access through a different payment system. And community health centers are federally qualified health centers. Again, a special designation or a designation that brings with it federal grant dollars, brings with it different payment schemes in both Medicare and Medicaid programs. Emergency departments, new configurations. There's legislation pending in Congress. Senator Grassley is the lead author on the rural emergency care hospital concept. That's very similar to what Michigan had done with a 24/7 emergency capacity and building some services around that. Primary health center, that's a model that has been developed by Kansas and 3 other states, currently in pilot testing. They've done it either as a 12-hour primary health center or a 24 with some emergency capacity, emergency service capacity as well within that center. So the point of that illustration of what one does in facing a current crisis or current problem was twofold. One, keep in mind the vision and where you want to be. Two, with some of those examples I wanted to point out, there is a pathway that one could create and follow in communities that appear to be in severe crisis because of a hospital closure. And speaking about the pathway to the future, how do you do that now? If you're able to come out of this kind of crisis environment, think more as the task force will be doing. What is that pathway? It starts with a consensus about what the purpose is. You need to go back to some vision statement. What are we really about? What are we after here? And then committing the resources, both time and money. It's laudable that that's being done here in Georgia. There are other states around the country that are taking similar actions. And then developing a blueprint that has specific steps and milestones. As the task force continues its work, I'm sure that's what they will be doing, is looking at, okay, we've got this vision, here's where we want to be, what are the steps, and by milestones, we need some kind of timeline. What do we want to accomplish by when? And then secure any necessary enablers. Sorry, left a letter out. including federal waivers that will incorporate changes in Medicaid, or more globally, the 1332 waiver reference you heard earlier. Use the health insurance marketplaces or exchanges, or whatever we may be calling them a month and a half from now as we finish the current work at the federal level. And use that structure to move toward the kind of private-based changes the Lieutenant Governor talked about, and also use effectively whatever subsidies or tax credits come with the evolving public policies around making health insurance more affordable. A state blueprint along those lines can draw on work that's already underway and available through some national associations. I had the opportunity to provide input to what the National Governors Association has been working on for the last, I'd say, year and a half now, and I think their documents are starting to come out on their ideas of what can be done with rural health care delivery and finance around the country. The National Conference on State Legislatures is another source. The Council on State Governments, I just came from speaking to them, their Midwest group, yesterday afternoon, and the kinds of exchanges that go on within that council about, well, what are you doing? Here's what we're doing. Other states, the Vermont blueprint is a blueprint based off of the primary, the patient-centered medical home model, and taking that statewide and what that means for integrated services throughout the state of Vermont. Pennsylvania has just started a new demonstration where they've managed to bring to the table Medicaid, Medicare, and the major private carriers in the state to talk about a demonstration of an all-payer methodology for changing the revenue streams to local hospitals, to move it from specific service by service to closer to a global budget, which Maryland has already done throughout the state. And I identified Pennsylvania instead of Maryland here because in Pennsylvania, the demonstration is rural. And so it'll be interesting to monitor that, see how they're able to do that. The Quad State Initiative of Kansas, Colorado, New Mexico, and Oklahoma builds off of that 12-hour or 24-hour primary care model, but has a lot more detail. My notes include about 3 pages of single-spaced notes I took from their discussion a couple of months ago, what they're doing across those 4 states. So there is a lot of company in making this journey and going down this pathway from other states. As you do that, our panel has suggested approaches to take toward changing the healthcare landscape. One of those, the first approach, is community-appropriate health system development and workforce design. And I chose to pick up the Vermont example here of an integrated health service model that includes multidisciplinary community health teams. That's what they're trying to put in place, or they are putting that in place statewide in Vermont. Governance and integration approaches, again, getting everybody around the table. The example that we use in the RUPRI document on this is the Mayo Clinic operation in 3 states, Minnesota, Wisconsin, and Iowa, and what they've done to integrate post-acute care in with acute care. And what they've done in doing that, by the way, is they're utilizing critical access hospitals as the primary site for a lot of post-acute care, rather than keeping the patients in Rochester in the Mayo Clinic. They're intentionally sending patients out to the critical access hospitals in those 3 states. The third one is flexibility in facility or program designation to care for patients in new ways. The innovations you heard about this morning, and where we might go if we picked up on the idea of person-centered health homes as the next iteration beyond even the patient-centered medical home. How we use health workers, lay health workers, how we use community health workers, how we use in a lot of rural America now community paramedics, so that you're utilizing that personnel in their time when they're not on emergency runs. And fourth, financing models that promote investment in delivery system reform. So having things like a payment Medicare now has for care management, primary care management, having that kind of payment, having a payment for the annual wellness visit that somebody talked about with Medicare. And just to give you an example of unintended consequences, again, picking on the annual wellness visit, I was reading a proposal on the flights last night about rural health clinics right now can't bill for an annual wellness visit if it happens the same day that a regular visit does. Because the billing system is set up as an all-inclusive rate, which made a lot of sense when it was set up. Because it was set up to provide them with a single payment, streamlining things, and a payment large enough to cover cover what they needed to do in a routine visit to the rural health clinic. But it wasn't set up to do a routine visit plus wellness visit, but you can't do a wellness visit the same day. So imagine here in Tifton or in Brainbridge or in other rural Georgia communities, and you're seeing somebody coming in who drove in 25 miles to get to the rural health clinic. And you provide them with their care, and you say, you know, you're a Medicare patient, you're in your first year of Medicare, you really need to have an annual wellness visit. Oh, but I really can't do that today. I want to reschedule you to come back. Well, annual wellness visit. Now imagine yourself as the Medicare patient. Do I really need to do that? Do I really need to spend another hour to hour and a half drive time going in and back? I'm feeling fine. I'm not going to do that. We missed the opportunity, the kinds of diagnostic procedures that you just heard about with that patient by not getting them in for an annual wellness visit. So we need finance models that promote a different model of delivery, and we need to get out from under the trap of some of the unintended consequences of what was, again, you know, I'm one of the people as an advocate when I worked with the National Health Association for that rural health clinic payment, but recognizing that's a dated model now and we need to transition out of it. Some examples of just potpourri of examples of what's going on in other states. Alaska has a community health aid program that they're well known for. Now you can imagine this in Alaska. They've got sites where there's just literally nobody there as a healthcare professional. So they've trained community health aides. North Dakota, interestingly, has taken up a model that was generated out of urban environments like San Francisco, the Program for All-Inclusive Care for the Elderly, or PACE model, and adapted that to a use in a multi-county region in North Dakota, where they're sending out workers, healthcare workers, into sites, integrating the care much more effectively in a PACE model. The Care Coordination Organization is an ACO parallel in Oregon, initiated through their Medicaid program, that is really affecting a lot of delivery. We've worked with the Hospital Association in Oregon as they've adapted to new payment models promulgated by the CCOs. Community Care of North Carolina is another one with integrated care and patient-centered medical home. Prime West in Minnesota is interesting because that's a county-owned managed care organization under Minnesota's Medicaid program that's administering that program in a 13-county region of Minnesota, and they're doing it in a way, again, that integrates services under a total cost of care model. So they're integrating human services along with health services. Now, bringing all that home to Georgia, I really don't have to do this because you've already heard great examples this morning, but bringing it home to this state is to use Medicaid as a policy lever. We've heard about that both from the previous speakers and from me in terms of waivers. Working with systems like the Stratus Healthcare Network that's grounded in part here in Tifton, where you've got a more regional reach of hospitals and other organizations already collaborating, taking advantage of innovative delivery modalities like we just heard, providing technical assistance and evaluation expertise from the universities that are very strong throughout this state. And I threw in a last example that I just learned about a few days ago, because I think this is just getting underway with communities and local hospitals, and that's a program funded through the Rural Hospital Flexibility Program in the Office of Rural Health here in Georgia that uses community health needs assessments as a way for critical access hospitals to get a better picture of what are the needs in our community. That process includes then what steps do we take to meet those needs, which brings us back toward, in the parlance I've been talking about, the total cost of care approach or total health approach. Might even lead to another way of creating accountable health communities. That's thinking down the road. I know this is just getting underway with the CAHs through the Office of Rural Health here in Georgia. Some takeaways. The time is right now to move to a new healthcare system. We've had places like the Tifton Regional Center taking the steps they've been taking in the past few years all around the country. it's time for us to learn from that, pick up that momentum, and take it forward. But that requires carefully designed strategy to do it well. We don't want to make the same kinds of mistakes we did with that all-inclusive payment in rural health clinics. Make a change now that has an unintended consequence, inhibiting something more creative down the road. We do, and I wanted to put this in as a special part of this presentation as I did, recognize there are specific changes we need in the near term to deal with in many of our communities here in Georgia and around the country, to deal with that problem of the sort of foundation we built a local healthcare system around. An acute care hospital in many places is shaky at best, in some it's really vulnerable, in others we've already lost it. We need to be thinking about what do we do in those places. And then as we do that, build a plan that fits all the pieces together. And my final point, as a point of emphasis, in building that plan, and you've heard this already this morning, partnerships are critical. Bringing the people around the table to design the plan, figure out how to assess both the plan as we design it and evaluate it as we start implementing it. And it's most important to be doing that through a lot of local action. There are many things we can do to facilitate that local action. Sometimes you need a player like a state committee we saw on telehealth to bring the people to the table. Sometimes you need grant funding to inspire the original innovation. Sometimes you need regulatory policy that gets rid of inhibitors or provides encouragement to folks. And you also need payment policy that opens up the possibilities. But it still all comes back to the local community being the originator of where we're going to go long term. And then for your reading pleasure later, I added the typical information slides, a lot about Rupri, a little bit about me. There's a rural health gateway that I encourage you to use as a great resource. And then I wanted to point to this last slide because there are places and organizations that will help as you look at specific innovations. So I put that in the last slide. Looks like I left out actually from that because normally this is all part of a rural health value presentation, and that's the Rupri connection that was in a previous slide. So with that, I'm happy to take questions.
I don't want to take too much time because I guess I'm standing between everybody and lunch, but you mentioned the scenario about the wellness check at the time of a problem visit, which is it seems so simple, but it's a big barrier. The same scenario occurs with patients with mental health problems, and they're in our clinics, and one of the barriers to integration is the fact that if you're having the same patient see two different professionals, but it's under one tax ID number, they can't bill for one of those services. And is any state been able to deal with that? Because again, a lot of that's Medicare or payer-based issue. And I think all of us feel like this integration of mental health and primary care has got to occur. But how are we going to do that when you can't get paid for it?
The short answer is no, I'm not aware of anyone who's been able to address it. A little bit longer answer, that doesn't mean it's not out there someplace and I just haven't heard about it. And I would encourage you to push that issue, push it through your organizations. You know, I will take that back to the National Rural Health Association and make sure that that organization is pushing that agenda item. I had the good fortune in a couple of weeks of facilitating a meeting for them around primary care, and I'll raise it there. That's something that we need to keep our eye on and try to get some changes. So thank you.
Yeah, I don't want to turn this into a political discussion at all, but if the Congress cannot get to a solution with what they're working on now, how likely is it that on the administrative side, with our homegrown Secretary of Health and Human Services that we might see more flexibility on the 1332 waivers for Medicaid.
Okay, I'm taking off the strictly research-based expertise hat and putting on my policy wonk hat and saying I would expect flexibility in 1332 and 1115 regardless of what Congress does. And frankly, I think we probably would have seen that regardless of the outcome of the election, because that's just the way things are headed. We're even more likely to see it with the outcome of the election.
One question that I would follow up with. You obviously talked about delivery reform, but you also talked about payment reform, and the two are equally important. The challenge as public policymakers oftentimes is to see the needed change within the delivery strategy across all of our states, or the entire part of Georgia, I should say. And how do you encourage the right kind of delivery structure? Because there's a certain ownership that exists that people are a little reluctant to get into a sustainable model for their hospital, which might be a triage center and other things that you brought forth, because everyone wants a hospital, right? And fundamentally, most would say, well, just give us more money and we will be fine, right? But that is not necessarily sustainable. So could you address, in your point of view, maybe from a delivery and payment structure, how do you create the reform measures that lead to a sustainable structure going forward? That's a big question.
It is, and it's one that in public policy we've been struggling with for a long time. As you were saying that, and I know we're running short on time, but I can't resist a 30-second anecdote. I was thinking back to a conversation I had with staff to the House Ways and Means Committee 20 years ago. And she asked me, why do we have so many rural hospitals out there? Shouldn't some of them close? And I said, well, Deb, the reason we have so many rural hospitals out there is exactly what you're talking about. Every community says we need to have that hospital, and no one has the ability through fiat to say, close it. Unless you want to do that at the federal level. Well, no, I don't want to do it at the federal level. I want to pass that down to the governors and have them figure out how to do that. So no one really wants to bite that bullet. So there are a couple of ways you address it. One is the emphasis I've put today on really getting the conversations underway and keeping them going at the community level about what do we really need in our community. What they're doing with the critical access hospitals in Georgia now is a step in that direction. That could eventually lead to an outcome where the community says, we want to keep that facility, but we want to convert it. We want to get out of inpatient care. We want to keep the emergency and surrounding outpatient. Then on the payment side, we need a parallel change to that, like the REACH bill that Senator Grassley has in the Senate, which says, all right, we'll allow for cost-based reimbursement at a higher level even for an emergency facility plus surrounding outpatient facility, provided there are no acute care beds there. So you're eligible for a higher level of cost-based reimbursement for what your community needs. If your community has made that deliberate choice, we're not going to try to be everything anymore in the community. So that's one way to do it. You said that's combining both an option at the community level and a payment way. The other way is what we've been experiencing for the last 7 years, or the other force, and that is you keep driving down the payment to a point where you just can't keep it going locally, and that's the 79 to 81 closures we've seen since 2010. I think that's the worst option. I think the combination of the community conversation and some payment changes like Grassley's bill or what's being demonstrated in Pennsylvania now, what Maryland has done, where instead of having cost-based reimbursement per service, you set a budget that can sustain the hospital, and every provider, every payer pays into that general budget stream. That's in the hospital example, and something similar for clinics as well.
Very well done. Great, thank you very much. Senator Hofstadler would like to make a
Yeah,
comment.
one comment real quick I want to say to the people here at Tift County is I wasn't aware of the grant that you'd gotten, that you're one of 32, and I believe the only one in the Southeast. And so I wanted to brief you a little bit about on what the state's actually doing. You're ahead of us. But we had legislation this last session that sets up a committee to look at integrating the data in the state in a form that will use data analytics on the back end. We also have legislation that's parked in Jack Hill's appropriations committee for next session to actually do it. And we also, then I want to say, we were awarded a grant as well. As of last Friday, we received an email saying that the University of Pennsylvania is going to help us. They're going to send people here. They work on this area for states all over the country. They've worked with Virginia that's done it and has eliminated veterans homelessness. They've worked with Michigan, who Forbes magazine says is saving $1 million a business day. And so I learned a little bit about grant writing too.
You read the book.
Mine wasn't as hard as yours, I'm sure. But we hope, I know you've got the frustration now of your data is getting there too late. We hope to be helping to solve that problem in the near future for you if this all goes well.
Thank you. Wonderful. Well, let me just wrap things up real quickly. First of all, remind everyone that Senator Burt will be leading a rural healthcare 180 task force conversation after our lunch. We will break for lunch and then he will come back. Again, let me just say a special thank you to Tiff Regional for the wonderful, wonderful work and leadership that you're providing to this region. It is exciting to see, and we look forward to even greater success going forward. And this was certainly very informative to the task force. Also to Emory, as always, you guys continue to make us very, very proud, and we appreciate the innovation, the leadership that you are doing for our state. And telemedicine truly is a huge part of the solution as we look forward to the delivery system of healthcare, and no one's better at it than Emory. So we appreciate very much you being here and presenting. And Dr. Mueller, thank you for getting the award for traveling the furthest and staying up the latest and giving us a wonderful presentation with the least amount of sleep. But you it challenged us as well, and we appreciate very much the innovation and the thought process in which you brought, and we look forward to continuing to partner with you going forward as well. So to the panelists or to the task force members, for everyone being here, thank you very much. We look forward to continuing this task force as we're looking to bring a better healthcare delivery system at a far more affordable rate for the citizens of our great state. Thank you all very, very much.